The next presentation is Bambang Darwono. Дуже цікава презентація. Чи завжди потрібно використовувати спондилодез при багаторівневому враженні поперекового відділу хребта?
Good morning. Thank you, Professor Resenko and committee for invitation. It's always my great pleasure and honor to join this meeting. My topic is endoscopic technique for multilevel rigid degenerative deformity. Do we need fusion? Nothing to disclose. Adjacent segment disease in the lumbar spine because the spine motion segment then changed to a rigid segment. Then the ASD occur at the motion segment above the rigid segment. Also in cervical, the spine motion segment changed to rigid segment, then ASD occur at the motion segment above and below. So what is the disease? It is aging or degeneration. The aging is a natural physiologic changes of the biomechanical construct of the spine. Life is changing and changing is life, including spine, musculoskeletal system, bone, joint, ligament, muscle, peripheral nerve, etc., experienced by everybody and could not be avoided, leading to a kyphotic deformity. So what is spine degeneration? Is a pathologic condition, damages wear and tear, and change the biomechanical construct in the aging spine. Occur at any age, but could be prevented and be treated if the etiology is identified. The changes of the biomechanical construct in the spine might be single or multi-levels and lead to a deformity in cervical and lumbar spine. Theory of cardiology starting with early degenerative cascade, posterior joint and intervertebral disc, and continue with late degenerative cascade and ending with multi-level degenerative lesion. We can describe his theory into three phases: phase of dysfunction, instability, and stabilization, a created enlargement of the articular process and osteophyte, but in deformity. Actually, Kirkcaldibilis only described two columns, the middle column and the anterior column. 45 years before Kirkcaldibilis, Bastrup already described the posterior column degeneration, development of osteoarthrosis and breakdown the interspinous ligament characterized by abutment, enlargement, sclerosis, and bursa. But due to limited studies in histologic and radiographic changes, the etiology was not well understood and this theory was forgotten in clinical practice. But in 2010, his study was supported by Bristol study and Auckland study. They studied 100 standing X-ray, 200 CT scan of the asymptomatic and symptomatic group, and 200 abdominal CT scan between the age 20 until 90, and published in Europe Spine Journal 2012. According to their observation, the lumbar spinous process getting larger and wider with age. They call the kissing spine. If the height and width increase, then the lordosis decrease. Now the loss of lordosis is not merely due to degeneration in the anterior column, but also by enlargement of the spinous process in the posterior column. Three-column theory of Roy Camille, 80% of the burden go to the anterior column, 20% go to the posterior column. So what the function of the middle column? It is control the burden, Crane theory. Now we can understand that damages also can occur in the anterior, posterior, and middle column. Three-column damage theory of cervical and lumbar degenerative cascade, it occur at the anterior, middle, or posterior, may suffer alone or together from inflammatory to compressive reaction and change the biomechanical construct of the spine motion segment multi or single and lead to a spine deformity. Published in 2018. The dynamic movement of cervical and lumbar spine need the natural stabilizer, that is the disc, fascia, joint, ligament, and muscle. So the stabilizer is disc, fascia, joint, ligament, and muscle. The damage in the degenerative spine, we call it deformer. It might be osteophyte, hypertrophy, facet, lamina, spinous process, and canal stenosis, or flavum ill-folding and hypertrophy. In the cervical, you can see deformer also, multiple disc rupture, ligamentum flava infolding, and also annulus rupture and nucleus extrusion. Deformer in bus-tube type 4, oblique abutment, create a top in this level and lead also to a deformity. Now, the nature of illness in rigid degenerative deformity is combination of two factors in three columns, the stabilizer and the deformer. The deformer dysfunction the stabilizer and create instability. Then it followed by rigid deformity stabilization phase. This is the three phases of the cardiovascular degenerative cascade in the cervical and the lumbar. The gold standard is open surgery decompression, in some way sacrifice part of the stabilizer, then we need artificial stabilizer to restabilize. The question is, if we could preserve the stabilizer, do we need fusion? In multi-level rigid degenerative deformity, the option of treatment is create spine rigid segment with fusion or create again the spine motion segment. The concept of endoscopy in spine rigid degenerative deformity is retain the stabilizer, just remove the deformer. That is what we call the first decompression, and the result is release the rigid deformity, reapply the stabilizer function, and in some way will reduce the deformity also. This we call the second decompression because the best decompression is deformity correction. The normal facet joint is a gliding joint in flexion, extension, and lateral flexion. So what happens in facet hypertrophy? This will lock the facet joint in deformity. To release the locked facet, we perform medial facetectomy, the IAP, inferior articular process, the SAP, superior articular process, then the lateral is already decompressed well. The case, male 74, rigid deformity and facet hypertrophy. Then we perform endoscopy, preserve stabilizer, remove deformer, medial vasectomy over the top decompression. This is a medial vasectomy. The IAP is white hypertrophy. Then we go to the SAP. Then we can see the lateral recess already will decompress. This is IAP, SAP, then lateral recess already well decompressed, and also we do over the top the contralateral medial vasectomy. The result is rigid deformity corrected, no fusion device, before and after, before and after, before and after. Another case, female 77, facet hypertrophy locked the facet joint, resulting a rigid deformity like this. Then we perform medial vasectomy, remove deformer over the top interlaminar and preserve the stabilizer before after, before after, before after, before and after. Result is rigid deformity corrected, no fusion device, before and after, before and after. Female 83, rigid degenerative deformity. We perform the same, preserve stabilizer, remove from medial vasectomy and discectomy, before after, before after, before after, deformity corrected, no fusion device, before and after. Female 55 with spondylolisthesis. We perform the same things, before after, before and after, deformity and listhesis corrected, no fusion device. Male 59, 30 years, fracture pars interarticularis and rigid degenerative deformity. 3 months, severe low back pain right sciatica, stenosis at the right side, and facet hypertrophy. Then we perform endoscopy, preserve stabilizer, removal, and medial vasectomy. Deformity corrected. Fracture parts also reduced. 1 month later, 2 months later, no fusion device. 3 months later, pars intraoculis already union deformity corrected and no fusion defects. After. Stable. Male 78, cervical fusion, C4, 5, 6, 7, 2012. 8 years later, 2020, severe neck pain to ASD C34, C71. C34 and C71. Then we perform unipersonal endoscopy, decompression, foraminotomy, laminotomy, and discectomy. C34 before and after. C71 before and after. And the day after, he smiled, no pain. No fusion device. The male 62, bedridden, data to cervical and lumbar spondylosis with rigid deformity. The left hand on the left hand. The foot cannot move also. So this rigid deformity, 3 level, cervical, and also the lumbar spine. Then we perform for cervical foraminal discectomy, remotive from preserve stabilizer. Also discectomy of the C34. And the result is before, after, deformity corrected, no fusion device. Then we perform also for the lumbar, the same, before, after, deformity corrected, no fusion device before and after. And he start to move the left hand, the right hand, also the leg, getting stronger. Set also, and start walking. Yeah. No fusion device. So take home message, endoscopy is developing instrument for degenerative spine. The concept is how to use it for cervical and lumbar rigid degenerative deformity. Retain natural stabilizer, just remove deformer. This will naturally release the rigid deformity, reapply the stabilizer function, and then will correct the deformity without fusion device. The best decompression is deformity correction. And this concept applicable for lumbar, cervical, and thoracic, either early or late cascade and other pathology, single or multi-level. Thank you for your kind attention.
Thank you very much, dear Bambang. Nice to hear you. Really nice presentations. Thank you very much.